Okay, so hopefully you can see these slides. If you can't see them, can somebody shout out, please? Okay.
Slides. I can see the slides. Fine.
Okay, that's great. Thank you. So this presentation was postponed from October. What I'm going to be talking about for the next 20 minutes is an opinion piece I had published recently in the European Journal of Risk Regulation. It's a forthcoming special issue dedicated to the European Health Union, which is obviously receiving a lot of attention now. So some of this research started life in a draft paper on competition during my sabbatical at the start of the year. It's a piece of work I'm hoping to develop as things progress. So in overview, what I'm going to talk about is set out a bit of a sort of timeline relating to calls for European Health Union, and then use the different framings from the paper, being a narrative and a counter-narrative, about member state competence regarding national health policy and healthcare system organisation. So some of the motivation for European Health Union seems to stem from the idea and perceptions at the start of the COVID-19 pandemic that member state competence in healthcare had a sort of inhibiting effect on the EU's ability to take action in this area. So hence the narrative. So I thought it would be useful to have a look at Article 168.7 to see what it actually says in this regard. So a lot of the calls for European Health Union and the idea of greater coordination and cooperation between the EU level and the member state level involve Article 168.5, rightly so, but nevertheless, I think Article 168.7 merits further attention. It's a provision that's not received all that much attention in writings on EU health law and policy previously. But by looking at it, particularly in the context of competition and fiscal policy, we get this idea of a counter-narrative. In essence, that the interaction between the member state level and the EU level is more interconnected than it may first appear to be, perhaps even symbiotic. So using these two framings, I will then talk about COVID-19 responses before wrapping up with some concluding remarks about the paper as it stands at the moment. But before I move on, I'm aware that people may still be in the lobby, and I'm probably the only person who can let them in.
I will be letting them in.
Oh, okay, thank you very much. Thanks. Okay. So that in overview is what I'll talk about for the next 20 minutes. So the idea of a timeline, I was writing the paper in the summer, I submitted it in July, so what I was responding to and reacting to at that point was the Socialists and Democrats call, which came out in May. Things have obviously progressed somewhat since then, but along broadly similar lines. So we've had a European Parliament resolution in July. Obviously, calls for a European Health Union have received increased impetus by reference in the State of the Union address by Commission President von der Leyen in September. Subsequent Commission publications have started to flesh out some details last month, and there's growing movement with the manifesto for European Health Union in the last few weeks as well, or receiving more attention in the last few weeks as well, I should say. So the initial motivation seems to lie in this sort of broad narrative that EU level action regarding COVID-19 was inhibited by healthcare system organisation and health policy being a member state competence, and that this framework developed, in the words of Greer and de Ruyter, because the member states wanted it so. Consequently, the most viable means for expanding EU level intervention would seem to lie with the incentive measures under Article 168.5 as the most palatable option available to the member states from the member state perspective in the current framework. So Article 168.7 is obviously separate from this. seems to enshrine member state competence regarding national health policy and healthcare system organisation. And by looking at it, we can see how it has worked in connection with other aspects of EU law and policy. So looking at the wording of this and the framing of this, the idea of what Hanscher and Sauter have called a subsidiarity clause for healthcare is introduced with the Maastricht Treaty with Article 152.5, the original public health competence Article 129 of EEC Treaty, not including this reference to the member states, at least not in the same way. On the face of it, Article 168.7 would seem to be expanded by reference to Article 152.5, which would seem to sort of work to the member states' advantage. But I'd suggest that there have been some amendments which perhaps question this idea. And the first of these would be the removal of the reference to public health. So Article 152.5 talks about community action in the field of public health, whereas Article 168.7 is focused on union action with no further qualification. So the absence of public health perhaps suggests a sort of enlarged scope for union action. Certainly once you start looking in areas such as competition policy and I think fiscal policy as well, the idea of public health can take on more the meaning of a sort of the solidarity-based aspects of a healthcare system as distinct from private healthcare, which may be complementary or supplementary to this. Hanscher and Sauter talk about a contrast between Article 152.5, as they're focused on, and the Patients' Rights Directive, which covers all types of curative care without distinction to the funding regime. So First Amendment being the removal of public health. The Second Amendment suggests a kind of dilution in sort of focus, in that Article 152.5 talks about community action fully respecting the responsibilities of the member states. Article 168.7, union action merely respects the responsibilities of the member states. So with merely respecting, this perhaps leaves more room for EU involvement. Van der Gronden and Šešček have previously suggested this indicates a delicate and sophisticated balance between EU and member state competence. We see this coming out in some recent competition decisions in connection with Slovak health insurers, for instance. The idea of a delicate and sophisticated balance between the two with regard to findings by the General Court that competition law would apply to Slovak health insurers, but then subsequently the Court of Justice finding that it wouldn't. And last, but the most obvious amendment is the addition of the second sentence in Article 168.7. So this seems to explain in a bit more detail what the responsibilities of the member states include with regard to this competence of relating to healthcare system organisation. Focusing on it, I think there's a bit of an ambiguity that comes out in some language versions of the treaty, certainly in the English and French version, possibly less so in the German and Dutch, relating to the them, the last word. Obviously, and I think the most logical interpretation is that resources assigned to them, the them refers to management of health services and medical care. It's also possible to read it as meaning member states. So member states manage the allocation of the resources assigned to them. So when you think in terms of EU fiscal policy and across the range of member states, the different levels of fiscal policy assessment to which they may be subject, there's clearly perhaps more of an EU level influence on the resources available at a member state level to be available in connection with healthcare. But on the face of it, it relates primarily to the management of health services and medical care. So, having looked at the wording of Article 168.7, you can perhaps start to ask, well, if this does give member states competence to organise their healthcare systems and to define their health policies. How far does this sort of freedom extend? For example, does it confer freedom on member states to experiment with competition in healthcare? This is an aspect of the paper which wasn't developed in the published version due to reasons of space. So with this question, the answer could be, if so, if it does confer freedom, then how much? And if not, then what is the role of Article 168.7? So from a competition perspective, we seem to have a sort of different distinctions coming out. So Pross has previously suggested that the decision to experiment with marketisation reforms is indeed a national one. But the implication of that is that decisions have consequences, and the logical consequence of engaging with marketisation reforms is the wider EU competition law framework. The antitrust and state aid rules then become applicable. And seen from my own research that the EU competition law framework can influence national reforms. Clear example of that being in the Netherlands, with competition reforms introduced in 2006. This followed the EJRR Bundesverband 2004 judgment, which established that competition law didn't apply to German sickness funds. So in order to further develop competition within Dutch healthcare, Article 122 of the Dutch Health Insurance Act 2006 provides that, in essence, even if EU competition law may not apply, Dutch competition law would apply to the private health insurers in response to the EU judgment in EJRR Bundesverband. We see it also, to a lesser extent, in connection with competition reforms in the NHS in England, where there's been a sort of large-scale borrowing of terminology from EU competition law transposed into a sort of NHS context. Andrew Angeli suggested that the discretion afforded by Article 168.7 is seemingly quite wide. So on the one hand, we have this idea of a sort of tipping point that experimentation with marketisation reforms can only go so far before it entails the consequence of greater EU level potential EU level oversight. Andrew Angeli has written on the subject, using it as a way of explaining the different extents to which competition and marketisation reforms have developed in England and in Scotland. So if, however, we could take the view that Article 168.7 doesn't confer such a freedom on member states, what is its role? In connection with identifying healthcare values at an EU level, so aspects such as universality, solidarity and high quality, Van der Gronden has suggested that it may lie more at the level of interpretation, insofar as it's possible to derive such EU level values from the objectives set by member states pursuant to Article 168.7. So what I wanted to establish with that aspect of the discussion was that there's a level of interconnectedness between the member state and EU levels, which may not be first apparent. And this continues with the fiscal policies as well. So obviously fiscal policies are quite broad. I've focused briefly on the European semester, which is intended to coordinate economic policies across the EU, and the country-specific recommendations issued by the Commission in connection with this. For example, Garben has described the CSRs as a particularly coercive form of soft law. There's this growing sense in which the CSRs are particularly influential. Paper by Greer, Jarman and Baton suggests that CSRs mark a turning point in EU approaches towards member state competence regarding healthcare system organisation. Azzopardi, Muscat and others have also indicated that country-specific recommendations are influential regarding national health policies. So the idea that the interconnectedness between the member state and EU levels comes in when it's considered that the CSRs mark the end of this assessment cycle, which involves both levels. On the face of it and in isolation, the 2015 CSR issued to France might be quite surprising, seeming to indicate perhaps that the Commission is nudging France in the direction of introducing competition reforms in healthcare. But once you put that in the context of the wider economic semester cycle, which includes not only country-specific recommendations but also country reports, it becomes obvious that the reforms mentioned by France in country reports from 2011-2012 eventually are finding expression as CSRs a couple of years later. So in 2011-2012, France was thinking about reforming the numerus clausus principle with regard to access to medical training. So that seems to find reflection in the CSR in 2015. Subsequent CSRs to France have moved away from this, focus on aspects such as pharmaceuticals, for example. If you see what reforms are ongoing in France at the moment, the Ma Santé 2022 programme makes reference to national legislation which has reformed the numerus clausus principle in a healthcare context, but from the perspective of widening access to healthcare, so nothing to do with competition. So it's trying to understand this interconnected relationship by looking at the wider context of what's going on at the member state level. With regard to the CSRs, there seems to be some sort of thematic approaches occurring. So CSRs around about 2013, 2014, 2015 were emphasising increasing competition across various sectors of member state economies as a means to address some of the issues coming out of the economic downturn of 2008-2009. So there's been a shift in emphasis since then, and in light of the COVID-19 pandemic, that is presumably going to be a main focus of fiscal policy instruments going forward. So just to give a further example of national reforms finding reflection in fiscal policy, and with Ireland as well. So a decade ago, there were proposals to introduce competition in the Irish healthcare system, which obviously clearly found reflection in the economic adjustment programme, so more coercive still than CSRs on the face of it. I understand that's been sort of abandoned at a national level in the meantime, and subsequently Ireland's been receiving CSRs which reference its current programme of healthcare reform, Slantercare. So obviously with the fiscal policy responses and programmes, we're seeing a variety of instruments being applied to different member states in different ways according to whether or not they're members of the Eurozone, according to levels of indebtedness as well. So that we see that there have been concerns about negative consequences for accessibility of public healthcare in connection with the fiscal policies that were extended to Greece, Ireland and Portugal, for example. So with the current situation, presumably these are considerations which will come into play again. So in terms of COVID-19 responses, I think questions of EU and member state interaction focus more on health policy rather than healthcare system organisation. Questions of whether or not national healthcare systems reorganisation is necessary seem to be occurring more at a national level as far as I'm aware. But what we're seeing with the COVID-19 responses is the sense of more union being wanted. Question how that really works. Is it really a sort of temporary response, or an extended temporary response, or something a bit more long-term and fundamental? And in the paper, I draw a distinction between direct and indirect responses, with the implication that it could be at the level of direct responses that more union is wanted and less at the level of indirect responses. So by direct responses to COVID-19, it's thinking in terms of Alemano's systematised as phase 1 and phase 2, the initial emergency and then sort of relaxation of risk responses. Examples would include, from the Pernhagen and others paper, the fact that the EU couldn't tell member states to increase ICU capacity, but obviously the implication would seem to be that that would be a national decision, but the EU level may have a role to play in facilitating that, particularly in cross-border areas. So the idea of more union being wanted seems logical if we're looking at sort of direct responses to COVID-19. If we're thinking of more indirect responses, then this might include, for example, continuation of non-COVID-19 related healthcare services alongside pandemic responses. May or may not be helpful to think of that as a sort of phase 3, a distinct phase or a sequential phase even. And I think there is a question there about whether or not either less union may be wanted or at any rate no more union than at present. So some examples of indirect responses could also include government support in respect of e-health applications. We've seen this happening in the Netherlands in a state aid case recently. It's a state aid case that was decided in the context of the Commission's temporary framework relaxing the competition and state aid rules. The fact that this sort of temporary framework relaxing the rules exists seems to revolve around Article 107.3 as opposed to, for example, the services of general economic interest exception, perhaps tells us some thinking, at least at present, with regard to sort of indirect responses, signalling more a sort of return to business as the old normal, if not usual. We also see in terms of indirect responses maybe differing levels of cooperation between public and private providers. We see this in Ireland, we see this in Portugal in response to the pandemic, which again may benefit from sort of temporary relaxations of competition law, but may indicate more fundamental changes within those healthcare systems and how the two sectors, the public healthcare sector and the private healthcare sector, interact. So that was just an overview of some of the things I touched on in this paper. The overall sort of conclusions I would suggest is that obviously Article 168.7 is significant. The calls for a European Health Union seem to be built around the member state competence regarding national health policy and healthcare system organisation. As Alemano has pointed out in the editorial to the forthcoming special issue, this doesn't seem likely to change. So the idea of this being a member state healthcare system organisation as a member state competence seems unlikely to change. What is changing is what EU citizens expect from the EU going forward. So if the health union is built around this sort of member state competence, so it seems to give it a sort of certain significance there. What we're seeing though, in terms of fiscal policy responses, for example, is that insofar as Article 168.7 represents a barrier, but it's possibly a porous one, there is scope for EU level intervention to shape national health policy and even to a certain extent healthcare system organisation perhaps in more or less indirect ways. I think we need to be thinking about going forward, and what I want to focus on more is the more explicit linking of health and economic and fiscal policies, the framing of health within the fiscal policies and conversely the effects there, and also in connection arising with health inequalities as well. I think these are the issues that need to be revisited in developing this paper further. So I'm going to leave it there for now, say thank you and see if anyone has any questions or comments. I'll just stop recording first.